All right, let's get right into it. In anesthesia, some drugs just help you drift off to sleep, but others take over the fundamental machinery of life itself. Today, we're opening up the playbook for the most powerful of these drugs, neuromuscular blockers. We're going to cover everything from how they work to how we reverse them and what to do when they trigger a rare but absolutely lethal crisis.
So picture it. You've smoothly secured the airway, the surgery is underway, everything feels routine. And then, the alarms start going off. The patient's heart rate is skyrocketing. Something is going terribly, terribly wrong. This is that nightmare scenario, the one we have to be ready for every single time we push these drugs.
So, to master this playbook, you first have to understand the field of play. And it all happens right here, in this tiny microscopic space between a nerve and a muscle. This is the neuromuscular junction. Every single drug we're about to talk about does its job in this one specific spot.
And the bullseye we're aiming for is this guy, the nicotinic acetylcholine receptor. You can think of it like a complex lock on the muscle cell. Its natural key is a molecule called acetylcholine. When it binds, the muscle contracts. Now, the really important part to remember is that this lock has specific keyholes, the 2 alpha subunits. That's where all the action happens.
Okay, let's talk about our tools. We basically have 2 main classes of paralytics in our arsenal, and you really need to understand that they work in completely different ways. I mean, they're 2 fundamentally opposite strategies to get to the same end goal: total muscle relaxation.
So first up is the one and only depolarizing agent we use, succinylcholine. And honestly, its structure is kind of brilliant. It's literally just 2 acetylcholine molecules stuck together. This design is what makes it so unique, and also what can make it so dangerous. It's not just blocking the receptor, it's a perfect imposter of the real key.
So here's how that imposter works. Succinylcholine binds to the receptor, and just like the real key, it forces the channel open. But here's the twist. It refuses to let go. This causes a massive, disorganized firing of the muscle, which you actually see as twitching or fasciculations. The channel gets jammed open for so long that the receptor just gives up. It becomes desensitized. And the result? Complete limp paralysis.
Okay, let's draw a really clear line in the sand here. Succinylcholine is an agonist. It aggressively turns the receptor on before shutting it down. Non-depolarizers, on the other hand, are competitive antagonists. They're much simpler. They just sit on those alpha subunits and act like a plug in the keyhole, preventing acetylcholine from ever getting in. The dead giveaway clinically, you see those fasciculations with succinylcholine, and you see absolutely nothing with non-depolarizers.
Now, if we look a little closer at the non-depolarizers, they break down into 2 main families. You've got the aminosteroids, like rocuronium and vecuronium, which rely on the liver and kidneys to be cleared. But then you have the benzylisoquinoliniums, like cisatracurium. These are special. They break down through something called Hoffman elimination. Just think of it like a self-destruct sequence that's triggered by the body's own pH and temperature. It happens right in the plasma, no organs required. This makes them the absolute go-to for those really sick ICU patients whose organs are failing.
Okay, so we've covered the drugs, but here's the thing. The most important and unpredictable variable in this whole game is the patient themselves. Certain medical conditions can totally change the rules and turn a routine drug into a deadly one.
Let's talk about something called receptor upregulation. After a massive trauma, like a severe burn or a spinal cord injury, the denervated muscles start to, well, panic. The body responds by flooding the entire muscle membrane with a huge number of immature, fetal-type receptors. It's basically screaming for a signal that it's no longer getting.
And here is the life-or-death reason this matters. These photoreceptors have a fatal flaw. When they get hit with succinylcholine, they stay open way too long, causing a massive, catastrophic flood of potassium out of the muscle cells. This can cause an immediate, fatal cardiac arrest from hyperkalemia. So the bottom line is this. Starting about 24 to 48 hours after one of these injuries, succinylcholine is completely 100% off the table. Now, on the complete opposite side of things, you have myasthenia gravis. This is a classic case of receptor downregulation. The patient's own immune system destroys their acetylcholine receptors. So with far fewer targets, they're actually resistant to succinylcholine. But, and this is key, they are exquisitely sensitive to non-depolarizers. Why? Because you only have to block a tiny percentage of their few remaining receptors to cause a profound paralysis.
All right, the procedure is over. You've managed the paralysis perfectly, but now comes what might be the most delicate part of the whole anesthetic, the exit strategy. You have to ensure a safe, a complete, and a totally verified reversal of that blockade.
And our tools for reversal have really evolved. For decades, we had neostigmine. It works by just flooding the neuromuscular junction with acetylcholine to overwhelm the blocker. The problem is, it has a ton of side effects, like slowing the heart, so you always have to give it with another drug. But now we have sugammadex. It is a total game changer. It's basically a molecular sponge that just finds and encapsulates rocuronium or vecuronium molecules, pulling them right off the receptor. It's cleaner, faster, and works at any level of paralysis.
So, how do we know for sure the patient is ready to breathe on their own? Well, the new 2023 ASA guidelines are crystal clear. Guessing is out. You must use quantitative monitoring. And there is only one number that matters, a train-to-4 ratio of 0.9 or greater. That's it. End of story.
And if you're wondering why the guidelines are so strict, look no further than this absolutely staggering statistic. The old clinical test we all used, like a 5-second head lift, they are dangerously unreliable. A full 80% of patients who can pass that test are still significantly paralyzed, putting them at a huge risk for problems after surgery. This is precisely why we have to measure.
Okay, everything has been textbook. The case is winding down. But then you hear it. An alarm. Then another. The whole rhythm of the room just changes. This is it. This is the crisis.
Your eyes snap to the monitor. The heart rate is climbing fast. The end-tidal CO2 is rising, and it shouldn't be. You haven't changed a thing on the ventilator. This is that moment. The one where quick thinking and pattern recognition will save a life. What are you thinking? What do you do right now?
You're looking for the classic early signs of malignant hyperthermia. 1. A heart rate that's going up for no reason. 2. A rising end-tidal CO2 that you can't fix by breathing for them faster. And sometimes 3. A rigid jaw muscle. These are the first signs that a metabolic firestorm is starting.
And this is the playbook you run. Immediately, no hesitation. Step 1, stop all the triggering agents. Turn off the anesthetic gas. Step 2, call for help and for the MH cart, loud and clear. Step 3, flush the system by hyperventilating with 100% oxygen at very high flows. Step 4, push the antidote, dantrolene, at 2.5 milligrams per kilogram. Then you start treating the immediate threats, like high potassium, and you start actively cooling the patient down.
Now, when that cart finally rolls in, this is why the specific drug formulation matters so much. To get that first dose in, with the older versions, you would need to mix up 36 separate vials. 36! With the newer formulation, Rhinodex, it's just 3 vials. In a crisis where every single second counts, that time saved is brain and muscle saved. It's a huge deal.
One last, absolutely critical warning. During an MH crisis, you might see arrhythmias. Your instinct might be to reach for a calcium channel blocker. Do not do it. When you combine them with dantrolene, you can cause fatal hyperkalemia and a complete cardiovascular collapse. This is a never-ever situation.
So, we've walked through the whole thing. The targets, the tools, the patient variables, the exit strategies, and the ultimate worst-case scenario crisis. The final takeaway from all of this is that being good at this isn't just about knowing the steps. It's about being deeply prepared for that one moment when the entire plan falls apart.
Because, memorizing the playbook is just the entry ticket. Being mentally sharp enough and calm enough to execute it perfectly under the most intense pressure imaginable, with a life hanging in the balance, well, that's everything. So the question you have to ask yourself isn't just, do I know this? It's, am I truly ready?